Short stature or stunting is nothing but height less than -2 standard deviation or below third centile for age and gender specific standard growth charts. Suppose if 4-year-old female is measuring 90 centimeters, then we mark 4 year and 90 centimeter. So then the child falls below the third centile, that is this red line. So the child is short stature or stunting. So what are the causes? What are the etiology of short stature? That is physiological and pathological short stature. For physiological short stature, we classify it as familial short stature or CDGP, that is constitutional delay in growth and puberty. In pathological short stature, we divide it into either prenatal cause or postnatal cause. In prenatal cause, we divide it into IUGR, intrauterine growth restriction, that is small for gestational age, IUIs, intrauterine infections like TORCH, and genetic syndromes like Downs, Turner's, and Sickle. And postnatal cause, one of the most common cause is chronic malnutrition. Height for age is suggestive of chronic malnutrition and it causes stunting or short stature. Chronic disease like heart disease, liver disease, or kidney disease. And malabsorption syndrome like celiac disease. And endocrine causes like growth hormone deficiency, hypothyroidism, congenital hypopituitarism, and Cushing syndromes. And psychosocial cause, because of some maternal deprivation or child neglect. And idiopathic. Usually idiopathic growth retardation have good response to zinc. And if zinc is not responding, we have to give growth hormone. Then we go for physiological short stature, that is familial short stature and CDGP. CDGP is nothing but constitutional delay in growth and puberty. So familial short stature. The child is less than third centile for height for age, but it is normal for the genetic potential of the child. It is normal for the genetic potential of the child. That is maternal mid-parental height we need to calculate. For males, we'll calculate by maternal height plus father's height divided by 2 plus 6.5. For females, we calculate by maternal height plus father's height divided by 2 minus 6.5. For males, we add plus 6.5. For females, we subtract minus 6.5. So target height is mid-parental height plus or minus 8.5. So we get the point mid-parental height. We add plus 8.5 to that value and minus 8.5 to that value. We get the range of target height. If child is falling under this age, this height, then it is normal for the child's genetic potential. So child is falling under physiological short stature, that is familial short stature. We can't do anything about it. So it is familial short stature. In familial short stature, there will be normal puberty. Puberty occurs at normal time, but final height is also decreased. As an adult, child is short stature in familial short stature. So we discuss about CDGP, that is constitutional delay in growth and puberty. Birth height is normal. First 2 to 3 years, the child falls below third centile and will have normal growth velocity after that. So the child will be having normal growth velocity. But adult height is normal for this child. To meet that, there will be delay in puberty and delay in growth spurt. Later, because of delay in puberty and delay in growth spurt, the child grows for longer period of time. So adult height is normal. The final height is normal in this. In familial short stature, puberty is normal, but in constitutional delay in growth and puberty, there is delay in puberty and delay in growth spurt. Because of that delay, there is height velocity which continues for 2 to 3 years extra in them. So final height is normal. But in familial, normal puberty, normal height velocity, because of genetic potential, but final height is also decreased. Final adult it is decreased. So we see the chart. The pink color one is familial short stature. Child is born short and grows short. Child is born short and grows short. Final adult height is below third centile. But in CDGP, child is born normal, but 1 to 3 years it will go below the third centile and it goes parallel to the red line, that is third centile, but there is delay in, see, 14 years delay in puberty. That pubertal growth spurt occur and it will reach the normal adult height. In familial short stature, there is family history of short stature. In CDGP, there will be family history of delayed puberty. So we check bone age. Bone age is nothing but how do? We take left AP wrist and hand X-ray. We take left AP wrist and hand X-ray for 1 to 13 years of age. For 3 to 9 months we take shoulder X-ray. For 12 to 14 years we take elbow and hip X-ray. That's how we measure bone age. So what will happen to, why we have to take bone age? We'll compare bone age with chronological age and height age. In familial short stature, bone age is equals to chronological age. Bone growth is equivalent to chronological age. As per the age, bone growth is there. Because of genetic potential, child is not growing. So bone age, that is because of the cartilage fusion and all, that age is normal for the age, that is chronological age. If child is 2 years, its bone is also developed for 2 years. But it is, but height age is less than bone age and chronological age. Getting it right? In constitutional delay in growth and puberty, bone age and height age are equal. So what is the bone age? Child is having so much of height age. Since the child grow for longer age, but it is less than the chronological age. Chronological age is 3 years. Bone has grown for 2 years and height is also of 2 years. Because of delay in growth and puberty, final adult height is met. This is how we differentiate physiological short stature. Very much important to differentiate between familial and CDGP. Familial short stature and CDGP, that is constitutional delay in growth and puberty. Physiological cause is one of the most common causes for short stature. Now we go for, so later catch-up growth occurs. Bone age, height age and chronological will be same in constitutional delay in growth and puberty. See, normal upper segment to lower segment ratio at birth is 1.7 to 1.9 is to 1. At 3 years it will become 1.3 is to 1. At 7 years it will become 1.7 is to 1, 1 is to 1. Sorry, at 7 years it will become 1 is to 1. At 11 years it will become 0.9 is to 1. If this proportion is maintained, we should check upper segment and lower segment in short stature. If this proportion is maintained, we call it as proportionate short stature. Proportionate short stature. If this proportion is not maintained, we call it as disproportionate short stature. Again, we divide disproportionate short stature into short limb dwarfism or short trunk dwarfism. Trunk means where the spine is there. So upper segment to lower segment ratio is decreased. Upper segment is mainly based on spine length. Lower segment is mainly based on long bones length. That is short limb dwarfism. So if lower segment is low, it is short limb dwarfism. If upper segment is low, it is short trunk dwarfism. So how does upper segment will become low? Because of spine affected. If spine is affected, upper segment will become low. If limb is affected, that is because of cartilage is affected. Cartilage is nothing but growth plate is affected. Then we tell it as short limb dwarfism. In short trunk dwarfism, upper segment is to lower segment ratio is decreased. In short limb dwarfism, upper segment to lower segment ratio is increased. This is the mnemonic to remember. In TB, mucus sputum is I. That is, the causes for short trunk dwarfism is TB spine or Carey spine or Pott spine, mucopolysaccharidosis or mucolipidosis, spondyloepiphyseal dysplasia, and hemivertebra. Hemivertebra is seen in Alagille syndrome, where we also call it as paucity of bile duct syndrome, where there will be facial dysmorphism, increased conjugated bilirubin because of paucity of bile duct. There is obstructive jaundice which increases the conjugated bilirubin. Along with the bile duct stenosis, there will be pulmonary stenosis also. Stenosis of bile duct and pulmonary stenosis with dysmorphic faces is a triad of Alagille syndrome. Alagille syndrome. Now we go for short limb dwarfism, where cartilage is mostly affected. In vitamin D deficiency, that is rickets, cartilage is affected, so it causes short limb dwarfism. Osteogenesis imperfecta, it's a disease because of type 1 collagen defect, where long bones are affected. Type 1 is there in bone, ONE is there in bone, so type 1 collagen is present in bone. So by type 1 collagen defect, it causes osteogenesis imperfecta. There are 18 types of osteogenesis imperfecta. There is triad for osteogenesis imperfecta, that is, it is also called as brittle bone disease. There will be deafness and blue sclera, deafness and brittle bones, and we treat with bisphosphonates, that is pamidronate or alendronate. And other causes for short limb dwarfism is achondroplasia. Achondroplasia is because of autosomal dominant condition causing FGFR3 gene mutation, fibroblast growth factor receptor 3 gene mutation, and will have features like trident hand, obesity, parathormone deficiency. IQ is normal in them. One of my MBBS friend was having achondroplasia. MBBS means good IQ. So IQ will be normal in achondroplasia. Short limbs, short fingers, and bullet-shaped vertebra. These are the features of achondroplasia. And other causes of short limb dwarfism is hypochondroplasia, congenital hypothyroidism, chondroectodermal dysplasia. Anything involving cartilage will cause short limb dwarfism. So these are the causes for short limb dwarfism and short trunk dwarfism. Short trunk matlab spine is affected, short limb matlab cartilage is affected. So what are the investigation we do for short stature? There are level 1 investigation, level 2 and level 3 investigation. Level 1 investigation we do CBC with ESR, urine examination, stool examination to look for fat globules and other stuff causing malabsorption, RFT and LFT to look for chronic diseases involving liver and kidney, calcium, ALP and phosphate to rule out rickets, fasting blood sugar to check for endocrine causes, and bone age estimation we do at level 1. If level 1 is showing nothing, like if everything is normal, we go for level 2 investigation. We do thyroid function test and karyotyping to look for chromosomal abnormalities causing especially Turner syndrome. In female, we need to do karyotyping to rule out Turner syndrome as a cause for short stature. At level 3, we go still more higher level investigations, that is celiac serology. Celiac serology is done to celiac disease is one of the malabsorption syndrome. So to rule out celiac disease, that is gluten sensitivity disease, we do celiac serology. Growth hormone stimulation test using insulin or clonidine or arginine. Insulin like growth factor 1 and insulin growth factor binding protein 3 we do for receptor level problems. And MRI brain to look for any pituitary or hypothalamus problem causing the short stature. Any tumor in pituitary region causing hypopituitarism might be the cause for short stature. So we need to do MRI. How do we manage this patient? First, we should treat the condition. That is, treat the cause. Whatever is the cause, we should treat the cause. Then, suppose if it is SAM, we need to give dietary advice, good nutrition, good protein for adequate growth and development of the child. Then if it is hypothyroidism, we give levothyroxine. If there is skeletal dysplasias, we can do limb lengthening surgeries like Ilizaro. And growth hormone. Growth hormone is given for Turner syndrome, small for gestational age with short stature and not having catch-up growth adequately. Chronic renal failure, before transplant we need to give growth hormone. And in idiopathic short stature we give growth hormone therapy. Zinc. And in idiopathic we can also give zinc as a treatment. Growth hormone, one of the side effect is pseudotumor cerebri. And we need to do regular height monitoring in the patient on treatment with short stature. Next class we are going to discuss about failure to thrive. Until then, like, share and subscribe.